It's my honor to introduce you to Dr. Shirwan. He comes to us from MU Next Gen Precision Health and will be presenting on Can the immune system be trained as a universal platform to prevent cancer in high-risk individuals? Dr. Shirwan is a Curator's Distinguished Professor and Marvin Hall MD Faculty Scholar in Diabetes in the Department of Pediatrics and Molecular Microbiology and Immunology. He's a Director, Division of Pediatric Research, and Associate Director of Immunomodulation and Regenerative Medicine Program at the Ellis Fishel Cancer Center, University of Missouri, Columbia. His research focuses on modulating the immune system to treat various immune-based diseases, with a particular emphasis on type 1 diabetes, transplantation, and cancer. Recently, Dr. Shirwan introduced an idea that the immune system can be trained as a universal platform to prevent the development of a wide range of non-viral cancers in high-risk individuals, an unconventional and unexplored approach to cancer immunoprevention, which has become a major focus of his research in oncology. Dr. Shirwan is a member of the National Academy of Inventors, recipient of multiple national and international awards, an inventor with 27 issued patents, founder or co-founder of 3 biotech companies, is widely published, has lectured at numerous national and international conferences, and is a member of several national and international societies. It is my honor to welcome Dr. Shirwan to the stage.
Good morning, everyone. What a morning. Thank you, Vicki, for that kind introduction. What an amazing, informative talk by Dr. Hines. Thank you. Actually laid the ground for my talk. I want to convey, my sincere thanks to organizer for putting this meeting together, Wilcoxon's Innovation in Health Sciences. I'm privileged, to be here to discuss a topic that could fundamentally change the way we approach cancer. That is prevention. Training the immune system as a universal platform to deal with cancer. And these are the cancers is unknown of etiology. As we look towards cancer treatments, I believe the answer lies within our biology, in untapped potential of the immune system to deal with cancer. So today, I want to leave you with one message. As we sit in this room, those of us who are fortunate, we don't develop cancer, even though cells in our body, as we speak, they are on their way with the potential of turning into cancerous cells. And the reason we don't develop cancer, it is because of the exquisite power of the immune system to recognize those cells early on and eliminate those. Those that develop cancer, the immune system, unfortunately, do not have that capacity to deal with cancer. The other point that I want to make is that any kind of treatment for cancer is really not to treat cancer. It is to treat the immune system. And when the cancer develops, the reason it develops because cancer and the immune system co-evolves. Cancer immune system always keeps a tab on the cancer. When the immune system fails, that's when the cancer develops. All the immunotherapies that I'll be talking about try to revitalize a failed immune system. And the challenge there is enormous. Then the question becomes, could we train the immune system to deal with cancer without the complications of cancer evading the immune system? And that's, I hope I will present data to convince you that indeed that's a huge possibility. And this has been the focus of our research by colleague Esma Yolko. She's in the audience, and I appreciate all over the years her input into what we're trying to develop. And this is my conflict of interest. So cancer is the leading cause of death worldwide, with millions of new cases. Indeed, per NCI, in 2024, 2 million people in this country were diagnosed with cancer, and over 600,000 people expired from this disease. World Health Organization indicated that 1 out of 6 deaths worldwide is because of cancer, with incredible global economic burden. In trillions of dollars in the United States is over $500 billion annually. And another important issue here is that unlike the developed world could afford costly treatments, underdeveloped world, the incidence of cancer is predicted to increase. And unfortunately, they are not as privileged as we do to have access to cutting-edge treatments. Therefore, developing approaches, as Dr. Hines indicated this morning, to prevent cancer in a manner that is not cost prohibitable is becoming really the key here. And that's what we're hoping to do that. Standard treatments for cancer include surgery, chemotherapy, radiation therapy, and been applied for hundreds of years. Although effective for certain cancers, unfortunately, they have incredible side effects because those are not precision medicine. They damage the healthy cells. And the other thing, they're not always successful. Recurrence is certainly a major problem. Immunotherapy revolutionized the field. For almost a century, the immunologists tried to make the point that the immune system is important in dealing with cancer, but we just did not have convincing evidence. Convincing evidence meaning clinical data indicating that that is actually true until 2010. A therapy is called Provenge, basically based on taking patients, these are for prostate cancer, cells from their body, basically presenting those cells with what they call antigen, pieces of a protein coming from the prostate cancer, and giving those cells back. Those were dendritic cells, trigger an immune response. And that treatment was approved by FDA in 2010, even though really the therapy wasn't home run. But I think what it did, it changed the mindset. Basically, it provided very direct evidence that yes, indeed, immune system can be harnessed to treat cancer. And then Jim Allison and Hanjo, they developed immune checkpoint blocker, as Dr. Hines indicated. Jim Allison with CTLA-4 Ig, Hanjo with PD-PDL1, Liping Chang was another individual really contributed to this effort, and Hanjo and Jim Allison, they won the Nobel Prize for it. And that really became the big deal in the field. And now every single cancer therapy, more or less, rely on immunotherapies. The concept of immune system can be harnessed to deal with cancer goes back to late 1900. William Coley was a physician at New York, one of the New York Memorial Hospital, treating an individuals with sarcoma. They amputated the leg. After almost 10 weeks, that individual expired from cancer burden, and that kind of hit home for him, and he went back, looked at the hospital records, and came across a case where an individual with cancer cleared his cancer because of an infection. And he went back and tried to find that individuals living in Manhattan, a German immigrant. Indeed, he found the person, and he found the person as cancer-free, and that kind of indicated to him maybe immune system has something to do with this, and he started using basically bacteria to challenge cancer patients, and he's considered to be the father of immunotherapy. We have another individual, Paul Ehrlich, a German physician. He's also the father of chemotherapy. He came up with this hypothesis that our immune systems surveys the body for cancer cells and eliminate those cells. It's called cancer immunosurveillance mechanism. And that really fueled a lot of effort on the part of the immunologist, try to have the proof of concept in the clinic that indeed immune system can be harnessed, as I indicated, until 2010, when we have the dendritic cell-based vaccine was approved. Now that we have several immunotherapeutic approaches are being approved by FDA, could we now harness the immune system to prevent cancer? Now, indeed, there are two vaccines, preventive vaccines, against cervical cancer as well as liver cancer, and both cancers, the etiology are viruses. We know what causes the cancer, and therefore these vaccines are developed by taking an antigens from the virus with immune adjuvants, and that has shown indeed it is possible to prevent cancer. However, 80% of the cancer, they don't have a known etiology. Therefore, it presents a challenge as to how do we develop vaccines against cancers without an etiology. What will be the tumor-associated antigen or tumor antigen that we can use, basically formulate the same vaccines that we have for preventing virally caused cancers. Indeed, several academic institutions in this country and other parts of the world working on this, so are biotech companies. The only problem is that we try to predict what the antigens are and then develop a vaccine accordingly. The only problem is that tumor is extremely heterogeneous. And as tumor develop, it changes its antigen landscape. So it is very difficult to come up with what we call neoantigens and have a vaccine in a timely manner and administer to that person. And of course, this will be all therapeutic, right? Because we're talking about cancer. So let's just talk about immunotherapies, the pros and the cons. First of all, they're mostly cancer specific. Therefore, the adverse effects are not as pronounced as standard treatments. They have, because of that, they have better safety profile, also they have better efficacy. And the reason they have better efficacy because we're trying to revitalize a failed immune system. And indeed, what we call immune memory is critical for controlling recurrences. Recurrences, basically kills the patient. The cons, they don't work against every tumor type. Even for the tumor types, they show efficacy. They're only effective for a small portion of patient populations. Another very important factor here is that the average cost of immunotherapy is between $100,000 to $200,000. So it is a challenge for insurance companies, and especially when we're talking about underdeveloped world. So cancer immunoprevention, it is a new paradigm to target, as I expressed earlier, non-viral tumors at precancerous stage. And that Dr. Hines talked about having the screening tools to basically identify high-risk individuals. And I'm hoping that, at least my dream as a basic scientist is that as we go for our annual checkup, hopefully the tools are there. One thing I think should be incorporated into that is basically check the person for their risk for developing cancer. The other, I think, important test that needs to be developed, immune fitness. Because at the end of the day, I have a pitch always to students. We have summer students coming for a fellowship, 2 months fellowship program. And one thing becomes really important is that we are treating, as I indicated, we're treating patients, cancer patients. The treatment is, in a sense, we're treating the immune system. You're giving immunotherapy, and we have no clue exactly what is the immune fitness. And the other thing is that literally all the chronic diseases, diabetes, dementia, they have immune dysregulation as underlying mechanism. So immune system is critical for a healthy life. So hopefully we'll be able to come up, and there are tools out there to also check the immune fitness of a patient, especially the patient is being treated for chronic diseases. So cancer immune system has always been perceived as a defense system evolved to deal with external dangers, and those dangers are infections. Now we recognize cancer is an internal danger. And we believe that immune system applies exactly the same rules to fight infections to the cancer, to fight cancer. And that is a new realization. With that notion in mind, we're trying to discover pathways or try to understand how the immune system deals with cancer as an internal danger, and that understanding has the potential to provide us with effective tools to prevent cancer. In this cartoon, I want to just go over how the immune system works. Basically, I always draw the analogy, to the military. You have I guess nobody sees my laser. Okay, well, I see. Anyway, it doesn't work on that screen. So the bottom line on the left, you have what we call innate immunity. And this is, if you want to draw an analogy, I always draw the analogy to Navy SEALs. Basically, they are trained to deal with danger, but they don't know what the danger is. And that's how the innate immunity, we call innate immunity, it is an unrefined and rapid response. Basically, when we are confronted with an infection, let's say a viral infection, bacterial infection, this innate immune system recognizes that and try to keep the infection at the bay, but at the same time, it interacts with what we call adaptive immunity on the left. These are particularly, T cells. This is a much more sophisticated system, and also it has a memory component. It allows that system to develop, and then together they deal with infections. The cancer, basically, as I said, the new realization, the same mechanism also deals with the cancer. However, cancer co-evolves with the immune system. There is a third arm of the immune system, what we call regulatory immunity, on the very top. This is the immune system that when we deal with infections, basically you're mobilizing your immune system, you're expanding your effector immune cells that deals with the infections. Once infection is gone, now the immune system has to come to the base level, because otherwise there is potential for collateral damage, for example, autoimmunity, and regulatory immunity exactly does that. The cancer learned a way to exploit the regulatory arm of the immune system to evade the immune response. And this becomes a major problem when it comes to immunotherapy, because it's not only you have to generate an effective response, but at the same time, you have to overcome these immune evasion mechanisms in place, and that's a pretty high bar. So therefore, it makes sense if we manage to start from the first phase. Can we train the first phase of that immune response to deal with cancer? Because much more straightforward, and you don't have to deal with all these immune evasion mechanisms. And indeed, it is this response on your left, the adaptive immunity, what we call T cells. Cancer immunotherapy basically is T cell centric, as Dr. Hine indicated. It has checks and balances, as I indicated. Once you eliminate a threat, an external threat that is pathogens, then the immune system has to be controlled to avoid collateral damage, and there are various cell surface receptor, what they call receptor and ligand interactions, like Dr. Hines indicated, checkpoint blockers. They revolutionized cancer immunotherapy, and those are, for example, CTLA-4, PD-1, PD-L1. We focused on another pathway. It's called immune checkpoint stimulator. This is checkpoint inhibitors. They put the brake, and we felt like an immune stimulant, that is, you push the gas pedal, that may help to generate a better response. We focused on what a pathway is called CD137. This pathway is critical for generating CD8 cells. CD8 cells are effector cells. They eliminate cancer, fight infections, and also it's critical, this pathway, for establishing a long-term memory response. So the only problem, these are some other attributes of this pathway, is basically what we call it is the most potent member of what we call TNF family. It is a large family. These are immune stimulators. It is the most potent member of that family. And as I indicated, it expand CD8 cells in a very robust manner and establish long-term memory, also improves their function. This pathway has pleiotropic effects. It also regulates regulatory immunity, meaning that it inhibits regulatory immunity, especially regulatory immunity exploited by cancer to evade the immune response. Indeed, agonistic antibodies have been developed for clinical translation. So it is a validated target for cancer immunotherapy. The only problem is that Merck as well as Bristol Myers, they develop agonistic antibodies. And agonistic antibodies, they have significant adverse effect, and their efficacy pretty minimal. We hypothesize that the adverse effects, they are not necessarily bona fide feature of this pathway, but rather than attribute of agonistic antibodies. Those antibodies, they do a bunch of other things. So we try to develop, use the natural ligand. The only problem is that this ligand for this particular pathway is only functional when it is on the cell surface. So we wanted to have a soluble biologic that you basically, in a test tube, you inject into the patient to do this. And we had to come up to generate a molecule that has function basically in solution, in test tube. And we generated this molecule called CYP01. It is a recombinant oligomeric form of the ligand, the natural ligand, which only has function on cell surface, but not in soluble form. So the very first thing the question that we ask is that whether this molecule has immune activity. And this is, I don't have to go into details. Again, I'm going to stay at a very high level. I apologize if those of you are sophisticated immunologists, but seeing a lot of students here, let me just stay at high level. So what we're looking at it in the red bar, basically, this is immune cells. These are CD8 cells. We take the cells, we purify these cells, and we put in the test tube. Then in the cell culture, we add our molecule, and we look at the proliferation of those cells. And that's what you see. There was a dose-dependent response. The more you add into the culture, those bars indicate the cell numbers, the more proliferation you see. And we use agonistic antibody. We got it from Bob Mittler at Emory, but he was Bristol Myers. He developed this antibody. He was generous enough to send us the antibody. Our molecule does a much better job than antibody. I don't show the CD4 data. On CD4, agonistic antibody doesn't really have much activity, but our molecule has a beautiful activity. So the idea here, we wanted to use our molecule as immune adjuvant for subunit vaccines against cancer. And those are early days before immune checkpoint blockers revolutionized treatment, before we show that they're actually effective. At that time, there was no cancer immunotherapy. And as I indicated earlier, one way the cancer evade the immune system is that you have your T effector cells, they infiltrate into the cancer. These are the cells that are going to eliminate cancer. Cancer uses a very effective mechanism to convert those cells, what we call T regulatory cells, meaning that these cells, the T regulatory cells, they suppress the immune response. Therefore, it evades the immune response. So cancer does this in a very effective manner. And here, this is what's called flow cytometry. It is on your right. On the very top, you look at it. FOXP3, it is a biomarker for T regulatory cells that suppresses the immune system. On the top, basically, we don't have our molecule. You see very high level percentage of T effector cells are converted into T regulatory cells. At the bottom panel, when we have our molecule, we dramatically reduce that conversion. So indicating it works. And then we try to understand how that happens. Again, I'm not going to go into the details of the experiment. It appears that interferon gamma on the bars, basically graph on the left, when we block interferon gamma, we could not see that our molecule prevents the conversion of T effector cells into T regulatory cells. So then we've shown that our molecule engages the receptor on effector cells, stimulate those cells to make copious amount of interferon gamma, and interferon gamma prevent basically the switch from effector T-regulatory implemented by cancer. Madhuredi graduate student in laboratory, then he tried to demonstrate this actually happens in vivo. These are a cervical cancer tumor, basically, in preclinical model. In control, the greens are T-regulatory cells that evade the immune system against cancer. We have a control molecule we used, assay. All those greens are T-regulatory cells. When we treated the animals with our compound, we dramatically reduced the number of T-regulatory cells, indicating that it's not only an in vitro phenomena, but also it's actually an in vivo phenomena. And then we had a postdoc, Rajesh Sharma. He wanted to test the efficacy of CYP01 as the immune adjuvant for a therapeutic cancer vaccine. On the left, we have cervical cancer. Basically, pay attention to the graph where we have closed circles. That is our compound, our CYP01. This is a vaccine setting. This is human papillomavirus causes cervical cancer. We use an antigen. We know it is being recognized by CD8 cells that eliminate cancer as a vaccine. And then we use other benchmark adjuvant, immune adjuvant, CPG, MPL. It is GSK's basically immune adjuvant for preventive cervical cancer vaccine. And our molecule did a much better job than the rest. The same thing we tested now, because this was a virally driven cancer, we also wanted to test in a setting of lung cancer. We used another antigen. It's called survivin. It's being highly expressed in lung cancer as an antigen. And in that setting also, we've demonstrated that our molecule, again, closed circles, indeed has very significant efficacy. This is in eradicating cancer. And then we tried to see, could we further improve basically the efficacy of our molecule, and we tried to combine it with GSK's immune adjuvant used for preventive cervical cancer vaccine. It's called MPL, and it was actually, we published in Cancer Research and made the cover of the journal. In the graph, on the closed circles, we had both our molecules as well as GSK's MPL immune adjuvants, and the efficacy, therapeutic efficacy, 100%. Our molecule, which is closed, triangle, did much, much better than GSK MPL, which is closed, basically squares. And then when we look at what are the potential mechanism, we did immunohistochemistry. We look at T-regulatory cells. These are FOXP3 on the top panel. If you notice, again, the greens are T-regulatory cells, and the red, these are CD8 cells. When we used GSK MPL, we saw a lot of green T-regulatory cells within the tumor. With our molecule, CYP01, we reduced the number of those cells. In the combination, again, T-regulatory cells, we didn't really change much, but when we look at what happens to effector cells, this is the lower panel, both our CYP01 and MPL, we've demonstrated both molecules allow CD8 cells to get into the tumor, and this is critical. One of the problems for some tumors, what we call cold tumor, they will not allow these immune cells get into the tumor to destroy the tumor. So the combination looks like our molecule downregulates, decreases the number of T-regulatory cells that get infiltrated in the tumor, or prevents conversion of the T effector into T-regulatory cells, and combination recruit more T cells, and that's basically what happens. So then we went ahead and we've demonstrated some other aspect of it. I'm not going to go into everything. The bottom line is that CYP01 does several different things. It expands your effector cells that eliminate cancer. It overcomes the T regulatory cells, the immunosuppressive cells, by various means. The other thing, what it does is it also induces antigen-presenting cells, dendritic cells that are critical to present the tumor antigens to effector cells so that the effector cells eliminate the tumor. And then next question we wanted to ask is that we also know it works on NK cells. This is an immune cell type, it's innate immune cell type. These cells, the first line of defense, against infections, and their role also in cancer has been proven. So we asked the question, is it possible that our molecule can prevent cancer? And this is the experimental setting. Basically, we took naive animal C57 Black 6. We basically treated with our molecule, and then we challenged with different tumor types. We look at to see, do we generate any anti-drug antibodies to our molecules, because it is a recombinant protein, and we felt like because of its composition, the way we engineered that molecule, it may generate immune response. We look at antibodies to it, and indeed that is the case. In the graph you see at the bottom, we saw pretty appreciable titers of antibodies to this molecule, and then we asked the question whether those antibodies will impact the efficacy of the vaccine. So these are the animals that have been treated with our CYP01 alone, and then we challenge with the tumor those animals, and then we use our vaccine to see, can we eradicate the tumor? This is in anticipation submitting an IND to FDA for a phase 1 clinical trials for cancer immunotherapy with our vaccine. And we've also shown in this graph is that there's antibodies to our compound did not have inhibitory function on the effectiveness of our molecules to expand T cells. And the way we did that, you take our CYP01, we pre-incubate with a serum coming from animals that have been treated with CYP01, and we've shown on the left that they had antibodies. So if antibodies is going to block the function, then we pre-incubate it, and then we put on T cells to see whether they can activate, expand T cells. If they don't expand, then it means antibodies are actually blocking that activity. And in the graph, in the yellow bars, we did not see any inhibitory effect. In a tumor setting, we've demonstrated, again, this was really a eureka moment, so to speak, something totally unexpected, at least for me. These are cervical cancer model, what is called TC1 control. All the animals, you challenge them. These are transplantable tumor. You challenge them, animal with the cells, tumor cells, they expire from the tumor burden basically within 40 days. And then we use our vaccine, and that is basically the top blue bar with downside blocked triangle. Those animals, of course, they did not develop tumor because there was vaccine. We expected. To our surprise is that it says pre-treatment in the red closed triangle. Those animals did not receive vaccine. But yet, the tumor did not develop in those animals. I had, at that time, I had a graduate student doing this, and then we had a postdoc to repeat the experiment because we just did not know how that can happen. That was totally unexpected. The take-home message is that it turned out to be actually true, and then we set up to test it rigorously. And in this graph, again, this is a lung cancer model. We've demonstrated when we treat the animals with 2 doses of CYP01 2 weeks apart, and then you challenge with the tumor 2 weeks later, the the majority of animals did not develop tumor in the blue lines. And then we've also demonstrated the efficacy is actually dose dependent. As we increase the dose at 100 microgram, 100% of the animals were tumor free. And then the question becomes, how long does this protective effect last? So we treated the animals with CYP01 and then we challenged them at different times to see the immune response, whatever modulation that we're doing with the treatment, how long that protective effect would last, as shown in this slide, up to 14 weeks tested, it was still effective. So the protective window is pretty wide. And then the second question is that, well, is this unique attribute of our compound or not? And we used agonistic antibody, 3H3, that I alluded to early, being used in the clinic, the human version. That agonistic antibody for cervical cancer against the TC1 in the green had no protective efficacy. The other question that we ask, does it work against any kind of tumor? And I'm only showing here lymphoma, a different preclinical model. In that model, it is also effective, and again, it is bona fide feature of CYP01, this immunoprevention efficacy. I'm not showing here, but we've tested against battery of other molecules. It's basically the same thing, and then because the recurrence is a major problem, we said, okay, this is great for immunoprevention. Does it work also as immunotherapeutic agent? This is a single agent. You challenge the animals with a tumor, surgically remove the tumor, and then treat with this molecule. And yes, the same is true in this case. The controls, all the animals developed tumor, tested animal that received CYP01, they control their tumor growth. So it works in prevention setting as well as controlling recurrences. And Dr. Yolko, as I indicated in the audience, she asked the question, these are all transplantable tumor models. How about spontaneously arising tumors? And she used a tobacco carcinogen-induced model, and in that model, treating again with 2 doses of this molecule, she demonstrated indeed it's effective in that model too. The red bar, number of animals, she measured the microscopic tumors, very significant difference between the CYP01 in the blue and the control. On the right, basically histology in the control, as you see, with the red circle and yellow circle, basically tumors in the lung. So indicating that not only in transplantable tumor model, but also in a setting of tobacco carcinogen-induced model is also effective. And again, this is something totally unoptimized protocol. And one thing now we're trying to understand what are the mechanisms, and we can actually improve the efficacy. I have a graduate student right now, Faiza Argush, is asked the question, what are the differences between agonistic antibody and 4-1BB ligand? Because, CYP01, because they're the same receptor, we thought maybe it is the affinity, and she tested that. In the interest of the time, I'm not gonna get into the details of it, but agonistic antibody had better affinity to the receptor than our molecule. So that's one difference, and we don't know what that means. We don't really have an explanation, and whether both molecules, they simply bind to the same sites on the receptor, and that has been shown to make a big difference between whether something is effective or not. And she did in 2 settings. This is a cell line that expresses the receptor, and she either pre-incubated with agonistic antibody and then used our molecule, which is graph on the left, the green bars basically our molecule alone. The orange bar first, those cells treated with agonistic antibody, and then staying with our molecule looks like agonistic antibody blocks the binding of our molecule, indicating they bind to the same site. The one on the right doing the opposite experiment, because agonistic antibody have better efficacy. As you add more, it replaces our CYP01 from the cell surface. So agonistic antibody has better efficacy, but both they bind to the same site. So we're trying to understand what else is going on. Is it because of signaling? That's something, experiment ongoing. We had another graduate student, Pradeep Shastra. He moved to MD Anderson. He did immunophenotyping on these animals. Basically, we took immune cells from these animals, treated with agonistic antibody with CYP01, asked the question, what are the differences? I just want to draw your attentions to basically bars marked with a square line. We found CD4 cells, these are T cells, to be highly upregulated in the case of our molecule, and also NK cells, and NK cells basically making interferon gamma. And then we set up an experiment to ask the question, what are the involvement of CD4 cells, T cells, NK cells, and interferon gamma? To make the long story short is that here we deplete CD8 cells, and these are the cells, effector cells that eradicate the cancer. When you deplete those cells, animals lacking those cells, it did not change the immunoprevention efficacy of our CYP01. And this was another surprise to us, because the immune therapies are really CD8 centric. So CD8 is not playing a role. However, CD4 cells in the orange, when we deplete those cells, we lost the efficacy. And the same thing is that we did with NK cells. NK cells, again, another effector cells that eliminated tumor. When we deplete NK cells in the green, we lost the efficacy. Control with CYP01 in blue lines, 100% of the animals, they were tumor-free. And then we went ahead and can we block interferon gamma? Indeed, when we block interferon gamma, it was basically demonstrating that interferon gamma is also important. So CD4 cells, NK cells, and interferon gamma are important in this immunoprevention approach. So, and this is basically the view really cancer immunosurveillance and immuno editing hypothesis. Immunosurveillance by Paul Ehrlich, as indicated early, and Bob Schreiber and others from WashU, they come up with the concept of immunoediting. What happens is that normal cells, they develop into cancer because of several reasons. And those cancerous cells, they are being eliminated by immune cells. On the left bottom panel is that these are different cell types, gamma, delta, NK cell, macrophages, CD4 and CD8. And if they don't eliminate, they go through what we call equilibrium. So basically cancer and immune cells coexist, but eventually cancer evades the immune system, and then immunotherapy becomes the name of the game. Again, indicating that if we manage to trigger or educate the immune system early on so that we eliminate any precancerous cells before it goes to equilibrium and escape. So that is something I think is going to be important moving forward. And there are tools available, and this is just, I'm not going to go through the details of the experiment. We look at single cell RNA and to see exactly who is up and who is down. And the bottom line, there are differences here. I basically indicated on the right. That is our CYP01 versus agonistic antibody on the left. So there were several changes. And then we look into this further, basically Venn diagram. We've shown that in some cases, both molecules, they causes certain pathways going up, certain pathways going down. and there are pathways basically between agonistic antibody CYP01, the opposite effects, and that is shown here. Again, I'm not going to go into the details. Now, our focus is that could we identify critical pathways? We know at least the CD137 pathway is targeted by our molecule. That's one pathway is important for the immune system to recognize cancer early on. But we know, given the challenging test that the immune system has to deal with, right? An environment full of pathogens. And the way immune system operates, we know it cannot put all of its egg into one basket. There must be other pathways. The question is that, could we identify additional pathways so we can come up with a much more effective approach to basically prevent cancer? So, in conclusion, I hope I convinced you that CYP01 has the capability to prevent cancer development using several different tumor models. And I've also shown that the cancer immunoprevention is a bona fide feature of this molecule. We're still trying to understand, get the crystal structure and all that to see exactly how we interact with the receptor. And it is possible that this molecule perhaps could interact with some other receptor. That's something we are right now pursuing, in the laboratory. So the whole idea is that we think, hopefully, moving into the future, we have this screening test for high risk. And if we demonstrate that this concept works in high-risk individual, then the question becomes, well, this could be basically part of a preventive approach, preventive vaccines for infections, for example, right? I'm just saying that is something kind of to keep in mind, but I think what's going to be important for high-risk individual like BRCA1, BRCA2, for example, we know that are like Lynch syndrome. The majority of these people is hereditary cancer, they will develop cancer. Those will be excellent population basically to deal with. So that's a schematic diagram. So really the idea is that let's understand better, let's discover other pathways. I think this is really exciting, and I'm as Dr. Hein indicated, really the future of medicine is going to be predictive medicine, prevention, patient customized, and hopefully for when we're dealing with the immune system, we don't necessarily have to patient customize based on the data that I presented. I just want to really give the credit the people did the work. I'm just a mouthpiece. I come here and I brag, but these are the individuals on the bench as we speak. They're working hard, and I'm grateful to their efforts. And my collaborators, as already told, Dr. Yoko is here. We have past members. I'm grateful to them. And the other thing I just want to point it out, especially the undergrad, is really, I always think the science is not a job. It's a hobby. Those of us fortunate doing science, we are doing something, we make a living, we're impacting, hopefully, the humanity. So I would encourage you, try to, if you're not thinking about being a scientist, or physician scientist, even better, to bridge the gap between basic and clinical, please think about it. I think this has been fun. It's been a fantastic journey for me, and I'm so grateful having that opportunity and pursuing that opportunity. And I'm grateful to National Cancer Institute, just to let you know that NCI recognized the power of prevention. They established Cancer Immunoprevention Network, 2023, had the inaugural RFA. We submitted an application, and we're fortunate. We are one of the 4 institutions in the country received funding to pursue this concept. I'm also grateful to the Raine Foundation. They came, we had a pitch to them, basically recognized the importance of what we're doing, and they provided us with significant funding to basically pursue this. And with that, thank you very much for your attention. I'll be happy to take any questions you have. Thank you.
Hi, thank you so much. That was a brilliant talk. Most of the studies that you presented, I believe, were in C57 Black 6. So one question I have is, have you tried it in P53 knockout mice or any other RB knockout mice that have a propensity to develop tumors later postpartum? That would be one question, and I have a follow-up question after that. I'll let you answer.
Yeah, that's an excellent question. I think that's always, we have to keep that in mind, the genetic makeup of whoever you're administering your treatment. So we know this is not, we also tested BALB-C. The lymphoma model is from for BALB-C. We tested against triple-negative breast cancer model as well. And tobacco carcinogen-induced model, that's AKJ, Dr. Yorko, that I presented the data. We're also right now working in a spontaneous breast cancer model. The data is still preliminary, but it appears that it is effective in that setting as well. Great question.
As a follow-up question, what's known about the pharmacokinetics and pharmacodynamics of your molecule in live animals? How long does it persist? Where does it go in the body? Things like that.
Another great question. We have not really addressed that issue. I think that's a critical issue that needs to be addressed. That in mind, we are trying to also develop other delivery vehicles. And those are some of the things that we've been working on it. But the fact that the impact lasts for a long time, I would expect that pharmacokinetics probably will not be pretty fast, just like any other biologic, but we have not done that. Great question.
And a final question, I'm sorry. Is there any consideration of using Moderna-like technology to deliver this kind of interesting molecule that you've created?
Well, indeed, I have a postdoc, Young Lee. As we speak, she's administering those vaccines. It's not vaccine, by the way. I'm sorry. Moderna mRNA technology. Yes. I guess no more questions? Thank you.
Thank you, Dr. Shirwan, for your knowledge, your passion, and your curiosity. It's probably not a stretch to think that most people in this audience have been affected by cancer one way or another, by themselves or a loved one, and to think that in our lifetime we could see the prevention of cancer is amazing.